Okay, fine. Thank you so much.
The next talk is by Dr. Anvesha Mitra. She'll be talking about the comparison of lid reconstruction surgery with and without using 10/14F catheter as tissue expander. Dr. Anvesha, yeah, please go ahead.
Good afternoon, everybody. The topic of my paper today is comparison of lead reconstruction surgery with and without using 10 or 14 French silicone Foley catheter as tissue expander. I have no conflicts of interest to disclose. Now, resection of tumors or following trauma or congenital anomalies can leave large eyelid defects and hence require reconstruction. Conventional tissue expanders are expensive and may not be a viable option for people in the developing world. We have introduced the 10 or the 14 French silicone catheter as an expander device. It is commercially available in market and hospital settings. And in this procedure, there is temporary expansion of the skin and muscle complex. This expanded tissue is used in tensile rotation flap. The principle of this expander is that it is accomplished by placing a balloon-like expander underneath the skin, and there is graded expansion of the balloon with normal saline or balanced salt solution. Once a new skin has reached its desired size, the tissue expander is removed and the new skin is redistributed. This is a diagrammatic representation of the expander or the 10 French silicone Foley catheter. As we can see, it has been placed underneath the skin, and via the tube, balanced salt solution is injected into it, and it results in expansion of the skin overlying it. The aims or the objectives of my study was to evaluate and compare the surgical outcomes of eyelid reconstruction with and without 10 or 14 French silicone Foley catheter used as tissue expander in two groups of patients following excision of large malignant tumors. We have also evaluated the safety and efficacy of this expander and to evaluate the functional and cosmetic outcomes. Our prospective comparative interventional study over 18 months was conducted on two groups of 20 patients each, one group with the expander and the other without the expander. This study can also be extended to people with periocular scars or other eyelid scars, and exclusion criteria includes involvement of lymph nodes, distant metastasis, both lid involvement, corneal involvement, and orbital extension. We have evaluated the marginal reflex distance 1, left palpebrally superioris action, and the palpebral fissure height preoperatively, and we have also done a preoperative confirmation of diagnosis by an FNAC. Now, this is what a silicone Foley catheter looks like. It is a 100% latex-free silicone catheter. It is a two-way catheter with a 10 French circumference. It can be inflated up to a maximum of 10 ml. And it is completely inert, and there is no buckling due to its bullet-shaped tip. This is the surgical procedure. Now, the active zone of the silicone Foley catheter is 1 centimeter beyond its tip. First, we have tested the silicone Foley catheter outside the human body. Then, after deflating it, we now try to insert it inside and underneath the skin. We have first marked this area of the skin we need to expand with the help of a surgical marker, and now we expand the skin. This way it is kept in situ for around 4 to 5 days, and on the 6th day we deflate the catheter and the new expanded skin is then redistributed. Now, again, in the postoperative period, we have examined the patients for their LPS action, MRD1 and PFH. Now, the incision length in both the groups have been compared. In the group where we have used the silicone Foley catheter as expander, the incision length is significantly less than in the group in which we have not used the silicone Foley catheter and we have just gone forward with a conventional tensile flap. As far as MRD1 is concerned, in both the groups, at the end of 6 months follow-up, the MRD1 is statistically insignificant, meaning that the result that we have obtained for with respect to MRD1 is comparable in both the groups at the end of 6 months. We have obtained similar results for palpebral fissure height and LPS action as well. Now, this is a diagram, this is a table showing that the MRD1 palpebral fissure height and LPS action at the end of 6 months for both the groups on follow-up is not significant, meaning that in both the groups, the results with respect to MRD1, PFH, and LPS action are comparable. This approach allows for tissue expansion temporarily, permitting the closure of eyelid defects, typically not possible with tensile flap reconstruction. This is not vision limiting because we do not close the lid. The flap can easily be rotated and there is minimal dragging force involved. The suture tension line is markedly reduced and thus wound dehiscence is absent. Incision line is also reduced as we have already seen. There is decreased scar length and faster rehabilitation, making it much more acceptable. The effectiveness and the applicability of the tensile flap can be increased with the adjuvant use of this tissue expander. Our study highlights the successful use of a novel surgical approach for eyelid reconstruction using a 10 or 14 French Foley catheter expander combined with a tensile flap reconstruction. There is excellent functional and cosmetic outcome. These catheters are both cost-effective and readily available. The successful results of this novel utility make it a reasonable and cost-effective option also in developed countries as well. We believe this makes it an excellent tissue expander for use in the developing world, where access to other more expensive expanders are limited. This is a photograph of a patient. We can see that there's a lid mass and the silicone Foley catheter is in situ. After deflating it and reconstructing the lid with a tensile rotation flap, these are the post-operative pictures. These are some of my references. Thank you.
Good, that was nice. I had one question. Did you get any reaction to the Foley's catheter
No, ma'am.
in any of your patients?
No, ma'am. Not a single case we had encountered any reaction.
You mentioned at the beginning that it is totally inert.
Yes, ma'am.
So that's why I thought I'd just confirm.
Was there any trichiasis post-op?
Post-op trichiasis, ma'am, we have only followed up the patient for 6 months. So as far as a 6-month follow-up was concerned, there was no trichiasis. We have not recorded any trichiasis in any post-op patients up to 6 months.
And when do you remove it ideally?
We remove it after we deflate the catheter on the 6th post-operative day, post-stage 1.
And suppose you did not use it, like in that case you showed, the last case that you showed. Can you just go back to your slides? Where first you inserted the catheter and then you did a tensile rotational flap.
Ma'am, this one? This?
It's
Okay,
not visible
sorry.
here. It's okay. I remember the picture. Suppose you had not done the Foley's catheter bit and just done a tensile flap. Would it have been equally effective?
Ma'am, actually for all the pictures that I've shown, I have actually inserted the Foley's catheter for all the pictures that I had shown of patients. So in patients where we did not insert the Foley catheter, we did encounter wound dehiscence in some patients in the second group, but with the first group where we have used the Foley catheter, there was none.
Okay.